Should we get started then, Lauren? Or should we give everybody a minute or two?
I think we could get started on just the intro.
Sure.
And let people keep joining.
Okay, good afternoon, everybody. Thank you all for joining us here at the June meeting of the Health Inequalities Learning and Action Group. It's nice to see some friendly faces and some new ones as well. And nice that everybody is trickling in. Today is an exciting session because we are learning about the GPOP and the enhanced services that has become available and to incentivize the utilization of a health inequalities template across the city that will help our fabulous colleagues at the council with data gathering and help us in general practice with some practical tools to mitigate some of the problems that we see in our patients. My name's Matt, I'm a GP. I work at East End Park, so tucked in just behind the Playhouse in the Bermondsey Hare Hills and Richmond Hill PCN. And we obviously deal with a fair bit of deprivation associated problems here in our surgery. As chance would have it, the fates have aligned for me this morning. And the patient that I saw just before coming onto this call, I had to fill out the inequalities template for them because they had problems with their housing, which was a really lucky coincidence for me, very unlucky for them. So we've got some really interesting talkers today. Shouldn't probably say that because one of them is now me. That sounds like an ego boost. My bit will be dry and boring, but the rest of them will be very interesting. So we've got Kirsty Turner from the, it says West Yorkshire IBC there. I'm going to assume that that's the ICB and a typo. Lauren's pretty good, but she's not perfect, and we all make typos. And Kirsty's going to give us a brief overview of what the new GPOP requirements are and what we have to do to meet those requirements. And I suppose it's really hard to not talk about it as a box ticky thing from general practice, because there are some things that we have to do in order to meet those requirements. But actually at the core of it is about improving services for the most deprived or the most people with the highest unmet need across the city. And you may not think that that applies in your patch, but actually there is unmet need due to discrimination or deprivation everywhere. And you might think that you work in a leafy suburb, but there will be patches of deprivation and there will be people who are affected by the issues that we're talking about today. And hopefully some of the tools that come through this conversation and tools that have come up as part of this work will be useful to you. If for no other reason than they might help you identify those pockets of unmet need within your population. So yeah, I've been lucky to work with the public health team for the last, what is it? It's definitely is it 2 years that we've been working together? It's probably. And before embarking on this, which I don't have any formal engagement with the council, it's just kind of been a serendipitous relationship. But before that, I had no idea about the hard work that they all do. And actually, when you put your head above the parapet, it's not always people firing at you. Sometimes it's people helping you. And that's what the guys at the council have been doing. So it's great. A little bit of housekeeping here. So we'll be recording this session. So those who can't attend today can rewatch it if they want to. If you're welcome to turn your cameras on or off. It's obviously easier for our speakers if your cameras are on, because otherwise they're talking to a slideshow, which I'm currently experiencing right now, but you don't have to. Yeah, feel free to put your hand up or use the chat. Certainly when I'm talking, I'm happy to be interrupted, and I would encourage you to do so. But yeah, or we can discuss questions at the end. The first thing to say about, I hope this isn't stealing any of Kirsty's thunder, but I think that the uptake for the health inequalities GPOP or extended enhanced scheme has been really, really good. I don't have it on particularly solid ground because I haven't heard it firsthand, but I understand that it's maybe every practice in the city has signed up, which is, as far as I know, a first. So that's very exciting. Right, I will stop ranting and I will hand over to Kirsty.
Thank you very much. I'm hoping everybody can hear me. I
thought I was all set up in the office, and then I couldn't hear anybody else, so I had a little panic. So yeah, I don't feel as relaxed as I was. So thank you ever so much for inviting me to come today. For those people who don't know me, I'm Kirsty Turner. I head up the primary care team at the ICB, and it just shows you I'd have totally overlooked that detail, Lauren. So yeah, it's good. The IBC has got to be slightly better than the ICB at the current time with organisational change. But anyway, we shall move on. So I'm just here. I think the agenda today really it flows along. So I'm really mindful that we've got experts coming to talk about the Fairer Practice Scheme, to talk about the Health Inequalities template. So what I just wanted to do was just to provide a bit of background as to why does the scheme look like it does, where does it come from. So hopefully, can people see my screen? Is that working okay as well? Slides have been shared. Looking for a reassuring nod, thank you. She says, we're desperately trying now to see if we can move them on. And of course they don't. Right, so bit of background. There has been a health inequality scheme that's existed in Leeds for probably about 7 or 8 years, if we look back. But the last time that the scheme was updated was back in 2019. So obviously we then went into COVID, and obviously it left things alone for that time. And so that scheme is just maintained. And it had a focus on ethnicity and first spoken language, smoking and cancer. During last year in particular, nearly all the local enhanced services were reviewed on the back of the BMA collective action. So we looked at kind of the provision of wound care as an additional scheme. There was additional investment in shared care monitoring. And we just didn't get to health inequalities. And as I said, the specification was very old fashioned if we really think about where we want to go. And I suppose what's been great is Lisa and Lauren joining the working group around schemes development. And so there's a real opportunity for this year to look at that health inequalities investment that's existed for a long time and kind of bring it up to date. You know, what we really wanted to ensure that we did was reflect it with what this group has been focused on. So the hard work of, you know, key individuals around this table, it starts to kind of bring it back up to date into what's really going to help support health inequalities. And I suppose recognising what Matthew's just said around, we recognise that there are different levels of inequalities across the city, and there's a sense that, well, we're not that deprived, but actually what the aim of the scheme aims to do is exactly what's just been said. It's kind of look at those pockets of health inequalities. There is something for everybody. We also want to keep it manageable as well. So what we have tried to do is what's already out there, and how can we apply this? So bring it up to date, keep it streamlined, keep it simple, and kind of that's why the scheme looks like it does. So I'll try moving on. So ultimately, what are we asking practices to do? So I think this is more or less split into 4 or 5 areas. So the first is ultimately complete the self-assessment, which is shown on the screen there in the right-hand side of the slide. Which is, you know, part of the toolkit provided by public health colleagues, which is that introduction to practice priorities for reducing health inequalities. And it really takes it kind of step by step, a simplified view around, you know, where are we in our practice journey in looking at some of these priorities, and kind of areas of improvement for each practice. So that's kind of action 1. We then ask for you to provide the name of Health Inequalities champion. So hopefully that's why quite a few of you are around the table today. It's because you've been identified as that Health Inequalities champion. And secondly, invited to join this network. So again, really see the benefit of that peer support amongst the group, really, in supporting health inequalities. We've then got an ask around reviewing the health inequalities template. And again, the work that clinical leads and colleagues around this table have done in developing the health inequalities template and rolling that out. It's about really looking at that template and actually how can we increase utilisation, how can we raise awareness within our practice, and again, that's not meant to be about box ticking. And again, I'm not going to go into much detail because I know it's later on in the agenda and I don't want to steal kind of others' thunder either, but it is about kind of raising awareness so that we can try and improve outcomes for individuals. And then the last part is really about reviewing the practice appointment systems around the 5 A's for access. So again, there's a template within the health inequalities specification, which again just asks a bit of a self-assessment around how accessible are our services, thinking about some of those population groups and for patients. And I suppose that really links into that focus on access overall, that there's a danger that we just move to whatever target's kind of being imposed. And so if you think about 90% access for clinically urgent patients, for me, we don't improve overall experience for both patients and staff if we just kind of move to switch on to box tick to get that template. For me, it's around how are we taking that holistic view to access models for our services. So again, that's why it felt really important to include that as part of that focus on health inequalities. And again, I really want to reiterate, this isn't meant to be about a new ask. This is about general quality improvement. It's about things that practices are already doing, but just trying to do it through that health inequalities lens. So again, focusing on I suppose the positivity of this group and that expertise, the ask within the health inequalities and inclusion enhanced services is about joining this network and really looking to kind of bring things here and improve kind of that peer support. So again, I'm not best placed to talk about the strength of the group, etc. I think kind of colleagues can do that for themselves, but I think it is great to see that people are here and people engage in that and look to kind of share best practice through this group. So again, because I'm here, because it's this group, I just wanted to reiterate that's why it was included within the enhanced service. The kind of link task, and again, I'm high level because I know Lucy's providing an overview about fairer practice. Because of the ask that we were doing within the health inequalities LES, we also recommended encouraged practices to sign up to the RCGP Fairer Practice toolkit. And that's obviously some further national support and networks. And again, won't steal Lucy's thunder, but I think within that resource, there are real practical actions that practices can take, again thinking about different areas that are included in the LES, such as access. There's elements about continuity of care, all really important things that I think are both important to patients and staff. So again, what we've encouraged people to do through the LES is just sign up to that, because you're already implementing elements of that by signing up to the enhanced service. So last slide from me, you might be pleased to know. What's the finance for this, I think, is a common question. And I think I'll go back to the start around, this is an enhanced service that's probably been static since 2019. And when this enhanced service was first brought about, it was weighted to practices based on their so recognising the Cahill formula, what we tried to do way back when was try and look at elements that Cahill wasn't picking up. So that they were things like deprivation, first language spoken, ethnicity, and practices were weighted, and the resource was divided proportionate based on those factors. So again, going back to the history of the scheme, it was also about incentive practices to make sure the data quality around ethnicity was improved, and during that time that has definitely improved. We're currently rerunning the formula because it was based on data that is now significantly old. I think practices have changed throughout that period, so we've had quite a number of mergers, and therefore it's right that we rerun that formula to make sure that it's as current and up to date as possible. So I can't say it's a price per patient because of that variability, but what we are trying to do is get to a position where we've got transparency, because currently it doesn't feel that transparent, but we're just currently undertaking that task. So my commitment to you is it'd be good to come back here when we've kind of run the formula, but it's also a question to the group around, are there other factors that you would like us to take into account when we're looking at that formula that would appropriately distribute this resource across the city? So the budget is around, I think it's just short of £1 million for this overall. And as I say, it's been proportionately adjusted, and 50% of the payment is paid up front and confirmation of the Health Inequalities Champion, and then 50% paid later on in the year. I think we'd initially put that initial marker in of October when that plan on a page is submitted. Obviously, we can be flexible with that, recognising, I guess, some of the priorities going on within practice as well. So I'm going to pause there. Just to confirm, though, we have had 100% of practices sign up, which I think is really positive. I think we definitely had some of those questions that you posed, which is, is this really aimed at us? We don't feel we've got, those inequalities. We're in a leaf suburb, etc., etc. But I think through talking to people, we've encouraged everybody to sign up, which I think is positive. So I'll stop there. Happy to take questions, or because of the linked kind of presentations from others, happy to park those later on. I can stay for the whole session, so I'll stop sharing my screen.
That's fab, Kirsty. Thank you very much. I suppose there's a couple of points that you mentioned that I just want to pick up on. One was about this group. And what it is really, it's a bunch of like-minded individuals who've come together to discuss the problems that we face. It's been a real supportive tool for those of us who've been attending. And in January, we had a bit of a conference in person, which was really nice to get the same room. And we've had some positive actions as outcome of this group. So one of them is the enhanced service that Kirsty's just filled us in about. The other one is that we've changed slightly the speaker brief for target, so that every topic has to mention how it touches inequalities, and that kind of came out of a conversation that we had in our conference in January. So the other things to say about the group is it is a really safe space. You're welcome to raise your questions, and we've had plenty of agitators through the group, and actually in this space, some of the topics that we talk about are quite provoking. Some of them are quite controversial. I'll put my heart on my sleeve and tell you that I'm a socialist at heart and a liberal, and that influences what I say and what I do. But that's not to say that my opinion's the only one that matters. So if things that we say are controversial, then please, call us out on it. Speaking of, Kirsty, I want to pick you up on the access that you mentioned about changing into digital. It's so hard when the ICB are coming for us and saying, if you don't do these X, Y, and Z with your appointment availabilities, then we will withdraw your funding. And we've had those thinly veiled threats from the ICB. So it almost feels like, on one hand, that your team, which is great, and this is what we do support, is saying, make your access more equitable, do what you can to remove barriers. And then on the other hand, it feels like we're being forced to put up as many barriers as we possibly can. Our population is skewed, our appointments are skewed to much younger as a result of recent changes.
So can I come back on that? Because I
Mm.
would want to know if you feel someone's come down to kind of, you know, force you or come down. So there's a difference, isn't there, between making things available versus the options. And I'm really clear that from my point of view, the digital is a choice thing. It's not a one size fits all. And if anything, I've been absolutely clear. What I'm more concerned about is when I hear that practices are refusing to take an appointment by somebody coming up to the reception desk, or refusing to book an appointment over the telephone. And so I do want to challenge, if that has a message that's come from an ICB team member, then I want to know about it, because I am absolutely clear that online isn't the only way, that we've got to enable those other options. So sorry, I feel really passionate about that, and that's never been kind of a direction that I've given. So if that's what you feel has been given, then yeah, I'd definitely want to pick that up.
That's great, and it's really nice to see you're passionate about it as well. So let's you and me pick this up at another time, because that is the impression that I've got, which is obviously wrong. So let's correct that later down the line.
Yeah,
super. Right, so our next topic, oh no, where have I put the agenda? Here it is. Our next topic is Hasantha. So Hasantha's a GP in Chapeltown on which surgery is it, Hasantha? Just remind me. I get confused with Chapeltown Family Surgery.
Yeah, it's the Chapeltown Family Surgery.
There we go. I did know. I should have backed myself. Hasantha has been instrumental in the designing of the Health Inequalities template, which has been really good, actually. And it's not just another kind of template which we all get a bit jaded with. It's got really practical advice and links and instructions on how to deal with some of the problems that we face when we're dealing with the communities that we all serve. So I'll hand you over to Hasantha.
Thanks for that, Matt. Yeah, so I'm Hasantha. I'm one of the GPs over at the Chapeltown Family Surgery. I've been there 20 years now, 21 years, so a long time. Can I get the first slide, please? So I think everyone knows what. Oh, is this the right slide set?
I'm wondering if it is, because these are the ones you just sent me, Samantha, but I think they might be the last ones.
They might be the last ones. Uh-oh, that's a good start.
So I can stop sharing and you can try and share yours, or if you quickly send them over again, I'll share.
Yes. Why don't I, if I pull up my speak amongst yourselves. Right. So now share. Is that working? I can't see
your screen.
We can see your desktop, Hasantha.
So if you make that full screen.
Yeah, is that it?
Yep.
Yeah, you're on.
Fantastic. Right, yeah, so I am Hasantha. I'm a GP over at Chapeltown. And like I said, I've been working there for 20 years. I came to this work a few years ago now, 4 years, 5 years, I think. We've been working on it, Lauren. It comes from basically from my past history. I got interested in health inequalities through reading the work of Michael Marmot and seeing him speak. And a number of GPs would go to his talks and they'd say, how can we as GPs help? And his answers were along the lines of refer to the social prescribers, advocate on part of your patients. But it didn't really feel terribly concrete. And so when we got talking, we thought what we'd do is try and create a template that was according to Michael Marmot's principles. But I wanted it to kind of, from all these years I've been working in Chapeltown, which, as you know, is a very sort of impoverished area. I kind of, what I wanted to do is really center it on the consultation, the GP. It's clear, you know, for any of us working at the front line, it's all about time. We just don't have much time. We have maybe 10 minutes, 15 if we're lucky. And our job is fundamentally to help people solve their problems. They come in, they have a problem, and they're asking us for help. So I wanted to kind of build solutions. We were clear that we wanted to build solutions into the template. And clearly, we're not alone in this work. We need to work together to kind of solve a lot of problems that we see day in and day out. And so it's all about collaboration. So we wanted to make sure that there were links in there to help the day job, basically. And ultimately, this thing isn't fixed in stone. We want it to grow. So we need feedback from you all, because we have an eye to the future and how it can develop. So it is a template, but it's also a toolkit. If you think of it not as something that you kind of are forced to fill out, but when you're seeing a patient and you're thinking, what do I do here? You know that there's somewhere you can go to, and where hopefully the solutions might lie. And the solutions, ultimately, for a lot of us, we've been trained about to work through the medical model, as any doctor here knows, especially if those of us that are of a certain vintage. And we were trained on the medical model. We started in hospitals, and hospital clerking is when patients come and you're trying to work out what's going on, get a diagnosis, work out a management plan, and ultimately to get them out of the hospital. That's what everyone's trying to do. But in general practice, it's not like that. In general practice, it's all about holistic care. I don't need to tell you this. I mean, you all know this already. But holistic care, it's moving away from the medical model, and now we're having to think about the social determinants of health. I appreciate that some of you may not be too familiar with some of these phrases. Up to now, we've been talking to the converted, really, I mean, at our meetings. And many of us kind of signed up to this whole idea. But hopefully, this is a way of introducing those who aren't that familiar to what the social determinants of health are. And ultimately, it's the difference between hospitals and general practice. It's the difference between the short term versus the long term. We can't say goodbye to patients unless there's reasons to, but we're not discharging anybody. We're there still, and it's from cradle to grave. And Lord knows now, I've been there for so long, I'm seeing grandkids, growing up. I'm seeing children seeing me now who I remember as babies. And so it's the long term that we're in it together. And we're trying to fix real world solutions, but we haven't got the time to do it in. In hospital, you may well have an hour, but we need to kind of work together. I mean, ultimately, we'll be seeing patients for years, aren't we? But each appointment is 10 minutes long. So it's an odd sort of thing, and we're under pressure a lot of the time. But in hospital, I heard about this today, actually, and you may recognise this idea that when we're clerking people, we get to the stage where there's a social history, and in the bad old days, people would write NB, as in not bothered. In Sheffield, where I studied, it was NFB, which was normal for Barnsley, which none of this is good, obviously. But the social history to us now in general practice is central to a lot of what we do. And that's where the social determinants of health come in. And that's where what we're trying to do with the template is bring the two ideas together, bringing the social model, the social determinants of health together with a medical model for the benefit of the patient in front of us. As has been alluded to, you know, when we sit down, we often say, how can I help? But ultimately, what we're thinking about here is before, during, and after. I mean, before the patient even sits down, this whole thing that we're trying to get out there is thinking about practice as a system, and, you know, what may be the barriers to patients coming in. If we upskill the reception team so that they utilize the template, potentially they may not even need to see us. For example, a thing that's often used is the housing template, the housing letter. A lot of patients in our areas, the poorer areas, are asking us for letters for housing, and that's it can be kind of galling or problematic. But there's something that's embedded in the template which allows you to just click on it, and it populates it. Thanks to those conversations we've had with the housing team, it populates it with everything, the letter with everything that they want. It's a couple of clicks. You can put some extra information if you need to, and then you hand it to the patient, and it takes no time at all. So that has been a big help to us. But so potentially even before they come down and see you, they may have some of these problems solved, and maybe they don't even need to see you. But then if they do see you, you have somewhere that you can record conversations. It's meant to try and stimulate conversations, because sometimes some people don't really want to go there. The people who are worried about the can of worms that can be opened up. But ultimately, what we're hoping to do is potentially, you know, reduce the work that you're having to deal with patients who might keep returning because their problems haven't been solved. You're not entirely sure what's going on, potentially. And within that, when you open it up, there will be lots of, hopefully you'll find lots of useful resources. I mean, besides the housing sections, we've put in a whole bunch of links to useful places. The neurodiversity hub, there's stuff that I've kind of gathered over the years that's in there as well about, you know, other resources around neurodiversity. In Scotland, there's a really, really good resource. But I really encourage you to start opening up, just kind of have a poke around, see what you find. I mean, ultimately for this stuff, if you do nothing else, just asking those first 3 questions on the landing page about, you know, are you struggling with housing? Are you struggling paying the bills? Do you need help around the social, you know, your social setup? Then that's a good start. But I'd really encourage you just to have a look around, have a poke around, because I am very keen to get any feedback from you as well. Because, like I say, I have been talking to the converted, and I would, you know, very much like to talk to people who aren't converted. There may well be a lot of people who think, well, this isn't my job. But we can come to that. But even but then the reason to do it is potentially you may be revealing needs that you weren't aware about, you weren't aware of in patients, and even in groups in your practice. You may well unearth stuff through those conversations. And the template is a way of recording this, so you can go searching in your records afterwards. So hopefully it's something that you can use for the benefit of the whole practice. But like I was saying, I get it when you say it's not my problem. You know, a lot of people do. As GPs, you know, is it our problem? Well, the answer is yeah, you're right. It isn't. It's our problem. It's not your problem. It's our problem. The whole, you know, it should be a Leeds-wide project. This should be about collaboration. It should be connecting different groups. It should be multidisciplinary working. That's what we're hoping this is going to help foster. I mean, and how we've set it up is that you ask the question, and there should be a solution right next to it. You know, do you have damp in your house? Yes. Well, there's a Breathe Easy Homes link right next to you. There's ways of referring into the heating on prescription. There's suggestions around the early help team. So there may well be things in there that you may well find helpful. I mean, the links into the kids template is really useful as well. There's things that are kind of embedded in there which are interconnected. So, you know, I'd like to think that this is a way of us all talking to each other and not working in silos. And if we ask the right question at the right time, which hopefully this is what will also be prompting you to do, you'll find that there'll be less repeat consultations, because what you've just done is solve the problem that might have led to, say, someone's mental health deteriorating in the future. But you've fixed it at the right time by asking the right question. And like I say, the future of the template, I mean, it's growing thanks to conversations we've had with the good people at York Street. There's a whole section on migrant health. And you know, as it's used, hopefully we'll be finding more granular data. You'll be kind of connecting the dots. You know, how many people with COPD live in houses that are damp. And like I say, this isn't just about these poorer areas. Well, it really shouldn't be about those poorer areas. Talking to doctors working in more affluent areas, in the leafy suburbs and more rural areas, there are definitely issues around, you know, nursing support, because people live far away. There's definitely issues around social isolation. There's definitely issues about stress and people being, you know, maybe rich but time poor and leading pretty unhealthy lives, and you know, the depression that goes along with it. So I think that if you use it, even if you think, well, no, this isn't for me, you might well be surprised. And if this helps you kind of create the data set that allows you to advocate for more resources in your patch, then that's a win for you. So, you know, I really would suggest that it's not just because it's not aimed at Chapeltown and Hales and the usual suspects. It's a citywide thing for a reason, because what we're doing is trying to improve that sort of proactive care. I'm open to questions as well. I hope that's me. I hope that's been useful to you. But yeah, so I'll hand back to you, Matt.
That's great, Hasantha. Thank you, Hasantha. Thank you very much. And yeah, like you said, the template has all those practical steps in it. And I'll just repeat it because not everybody was here. But the patient that I saw literally just before we came onto this call had damp in their house, and I have in fact, as a child, and I have in fact used that template to let them know. They also had, as kids, 2-year-old with raised lead levels as well, so that's either from their pipes or from their paint probably. So I've emailed the council to let them know as per the housing pathway on the template, which was very helpful, because otherwise you kind of not certain, should I be doing this, should I not be doing that? But actually it makes it pretty easy on the template, and now I've highlighted that problem, I can sleep a little bit easier, although I'm not expecting that those problems get solved immediately. So our next speaker has helped me breathe a sigh of relief. So it was touch and go whether Dominic would be able to make it. And then we had another presenter, Dr. Chiddick, who was potentially going to do it. And I was the third string to deliver this talk. So I'm very pleased that Dom has managed to turn up. So Dom is a GP based out of Sheffield, and actually his influence and touch has reached many, many GPs because he's been paramount in setting up one of the health inequalities focused fellowships, which I was lucky to go on when I first finished my training, and that's helped shape and change my career, and I know the career of many other GPs who've gone through it. He's worn many hats over the years, and most recently when we caught up, he was AI at the Health Education England. That was his baby, but obviously HEE is now gone, so I don't know if what Dom's up to nowadays, but he's here today with his hat from the RCGP on their Health Inequalities Board, and he's telling us about the RCGP Fair Practice Toolkit. So Dom, I shall hand over to you if you are ready to go.
Yeah, thanks, Matt. Hi, everybody. Lovely to be with you. I'm a Doncaster GP, actually.
Apologies.
But no, near to Sheffield, Leeds graduate. So nice to be with you all and seeing some familiar names and faces on the call. I won't take too much of your time. I do still work for NHS England a couple of days a week in an education role. I look after innovations in GP training, including AI and other things. Partner in the practice one day a week, and then voluntary work around health inequalities, helping to run Fair Health, which is a charity that produces educational resources to help address health inequalities. And I lead currently on the Royal College of GPs work around health equity, chairing their special interest group. And part of the work we've done over the past 18 months has been to develop something called the Fairer Practice Toolkit. Now, this didn't come sort of early enough really to fully align with the brilliant Les that you've developed, but there's an awful lot of overlap. And with your Hesanthas template you've just talked about, I think a lot of the same ideas really, and certainly the same drive for why we've created this toolkit. So I'm just going to spend a few minutes talking about that, if that's okay. And then I guess Lauren and Matt may say more about how it's going to fit in with the work that you do. What I'll do is I've pre-prepared a little message for the chat, so I'll pop that there because there's 3 links in there. One's to take you to learn more about the toolkit on the RCGP website. One's to look at a tracker website that I've created to help you to use the toolkit and engage with the toolkit. And the third is if you want to join our community of practice that we've got around the toolkit. Just on my laptop, so I'm going to lose sight of you as I share my screen. And I'll just rattle through these slides because I know I don't have long. So we created the toolkit similar to Hesanthas drive, I think, really, with the template work, is what can we actually do in general practice that will make a difference to health inequalities. I'm a really sort of practical, action-oriented person, and I was often left a bit frustrated by conferences and other things that left me, certainly activated and wanting to do something, but not too sure what to do. In my practice, we'd done quite a bit. We identified our patients living in the bottom 20% IMD. We'd done some enhanced work on cervical screening and vaccinations, immunisation. So bits and pieces, but I felt like there must be more that we could do, and there must be some evidence out there for what works as well. You don't need to scan the QR code, the link's in the chat. The toolkit consists of over 100 actions that are designed to be simple to more complex interventions that you can do in general practice to make a difference. They're themed into 18 different areas we'll look at, and they're in 4 different tiers. They're either foundation actions, which are low-hanging fruit, quick wins, maybe around access and registration, team well-being, that sort of thing, through to more developed actions in 3 other tiers. But there should be something for every practice, regardless of your starting point. So you can just browse through the actions, take a look and get started with something that makes sense for you. And we've gone with a toolkit approach because I suppose partly the success of the Green Impact for Health toolkit, my practice utilised that to improve how sustainable the care we delivered was. And these toolkits tend to offer like a ready menu of evidence-based actions, nicely structured. There's a bit of motivation around reward as you achieve things as well. And it's nice to be able to see and tick off and measure the work that you're doing. Regulators are very interested in this as well. CQC increasingly, with Boller, at the helm, who used to be Director of Health Inequalities at NHSE, CQC increasingly interested in health equity work within practices as well. We can share the slide so you can look at this, but this is just the process we went through. We did look at the evidence base. There's been some work in Sheffield and Cambridge universities looking at primary care interventions. So tried to include evidence-informed actions where they existed, and then the rest of it was sort of expert consensus from a working group of Deep End and other GPs and colleagues and patients. These are just some of the evidence sources. As I say, you can choose the actions that you want from your current starting point. What you'll find when you look at the toolkit is there's an awful lot that you already have done, and you'll be able to go through the toolkit quite quickly and tick off, do that, do that, do that, do that. You can provide a short bit of evidence there. You can upload files to the tracker if you want to. But really, it's about you just looking for the next step ideas, I suppose. So if you've maybe ticked off all of the foundation actions, you can start to look at some of the engaging actions. If your practice is more advanced already, maybe you'd be looking into these achieving and leading tiers, which are often about meaningful co-production with community partners and systems engagement and other things. So the idea is that you choose what works for you and what works for your patients. These are the different themes. Some of these have got more actions in than others. Access and flexibility is a really big theme, whereas values and behaviours is a bit smaller in terms of the number of actions that it has. And there's something here that pretty much covers all sorts of things, really. And we're hoping, obviously, that the toolkit will evolve. We're already working on a palliative care, sort of fairer palliative care toolkit theme as an example. So over time, the number of actions, I think, will increase, and we'll refine them as we go. I haven't really got time to give you a demo of the toolkit, but it was really going to be a demo of the tracker website. It's pretty self-explanatory. When you click on the website, click on the actions, you can then filter them by the different themes. If you create an account for your practice, then multiple people can join that practice, and you can collectively update your actions and keep a track of your progress. Over time, we hope that the RCGP will be able to implement an accreditation system so that you can be given awards for the work that you're doing. Each action, as you see it, tends to have a little bit of an overview summary, a preamble for what you're doing, and then suggests some approaches that you might want to take to implementing the action. And then it's got some web-based links to additional resources, a bit like Asantha was describing within the template. So we've tried to collate and collect all of the useful stuff that's out there. It's a 4 nations toolkit, so it's not England specific. So there are resources relating to all 4 nations. And we ask you to identify a focused patient group. And this is a group that you want to start work on at the beginning. It could just be those living in areas of socioeconomic deprivation, quite a wide, broad group, or you might say people experiencing homelessness, vulnerable migrant populations. It's about you choosing a population group that works and for you and will make the biggest difference to your community. We're trying to make it not about doing more, and I think this came across in Asantha's presentation as well. Rather than doing more, it's about refocusing your efforts. And that's what equity is about, I suppose, into doing what is going to matter and make a difference for the people that need it the most. The final thing I'll just mention is, where is it? No, I don't have a slide on it. I'll put a link in the chat very shortly. Having a conference in just 2 weeks, 2 weeks today in Manchester, the Radisson Hotel there, Fairer Practice Conference. There's still about 25, 30 spaces left if anybody's free and wants to make it. That's going to be a whole day of workshops, creative health activities, plenary sessions, lots of really great stuff that hopefully will not only switch us on to wanting to do something, but leave people with real practical tips and tools for what to do. I'll put a link in to how to register into the chat. Sorry, that was really quick, but I only had 5 minutes. Done.
It was great, Dom. Thank you very much. I really appreciate you taking the time to come and talk to us about it. And actually, while you've been talking, I've been scrolling through it and kind of looking at the things that we might do in our surgery, and a couple that jumped out at me. One that's really easy, which is in your first tier about the equitable registration. Because I think, despite the fact that a lot of us have said, most of our receptionists know, but walking the walk and talking the talk is different. And I still walk through the surgery sometimes and hear them say, "Where's your ID?" So we've definitely got some work to do. And it's interesting, a bit later down, you mentioned there's one, this is in the, easy, medium, hard, and extreme on the tiers. So it went down straight to the bottom. And the walk-in clinics for focused patient groups is a really interesting one, because we used to have walk-in clinics. It just ground us into the ground, really. Like, it became so hard to do it. The patient volume just became unmanageable. But it's nice to have that on there aspirationally, I guess.
That's it. Yeah, something for everybody.
Yeah, definitely. So yeah, there's some really good, nice practical stuff in there. So thank you very much.
Pleasure.
That leads us on to the final part of our agenda, which is space for discussion or any other business. So we've heard quite a lot today from 3 very interesting talking topics, and I'm just aware that we've had relative silence from the audience? Is that because the presentations have been beautifully comprehensive, or is that because people are shy? If you're shy, don't worry about it. You feel free to utilize the chat, but I would encourage you to get your thoughts, feelings, and opinions out while we're all here. So is there anything that anybody wants to ask or anything that anybody wants to add? Great. Oh, here we go. Oh, Lauren. We'll collect an FAQ, so please do send us your questions. Great. Fine. Well, if that's the case, then I guess we'll call it a day there. Thank you all for attending very much. Thanks in particular to our speakers. There's now a inbox, isn't there, Lauren, that is shared between us all. So those of us that are on the committee that organised the HiLAG have a shared email address, which I hope Lauren will be able to share. Lisa, you've got your hand up.
Yeah, I know everybody wants to go, so I won't keep it. But just to remind everybody, because a really big lever for the Health Inequalities template, which is available on your blue dot, on the housing tab, there, as Santha mentioned, we have a letter for housing. So if a patient does come to you and ask for a letter for housing, you can just print this off. It's an auto-populated letter, and you can give that to the patient if need be. Because we work over in the council now, we've physically gone over to housing and asked them if they need a letter from general practice for housing, and they don't anymore because they can see the Leeds care records. They don't really need a letter from general practice. However, if they are very persistent and still require one, there is an auto-populated letter, and really it's just a patient summary with additional BMI. So as long as you're okay for your admin team or your care navigators to give it out, it is there for you. So it's just in the housing tab in the Health Inequality template, which is on your blue dot. Thank you, Matt.
Thanks, Lisa. I may as well, since we've got 2 minutes, just share my screen. So this is a test patient, so don't worry about confidentiality. Hopefully nobody will pop up a screen message with anything strictly confidential. But the way that I actually navigate to the template is I use this little bar in the bottom corner. So health inequalities comes up there, and then it looks like this. Those are the 3 questions that Hasantha mentioned. By the way, our kind of plan for meeting some of the requirements for the LES or DES, whichever one it is to include these 3 screening questionnaires on our registration form. So when patients register, then they ask all 3 of these questions, which hopefully will give us a bit of insight into where people might need support. But this is what it looks like. And then the housing pathway is here. So does the person have damp or mold issues? If so, this is what you do. So this is what I did today. I emailed the damp and mold team about my patient. Super. Okay, well, thank you everybody for your time. We really appreciate you coming. Julie's just said the Fair Practice Conference. Would I be able to attend? I'm a Health Inequality Champion here at my surgery and I'm the PCN Care Coordinator. Or does it have to be registered bodies only?
Yeah, I've fought really hard to make sure that the wider team are able and welcome to attend. You will have to pay, whereas college members get the fee reimbursed, but it isn't too expensive. So you'd be very welcome, Julie.
Super. Okay, yeah, thanks a lot, everybody. So we've got another, when's the next meeting, Lauren?
We're hoping to get one in on the 15th of July before the summer holidays. So gotcha. Invites haven't gone out yet, but they will do soon. Cool. Okay, well, keep an eye out for the invitations, and hopefully we'll see everybody then. Goodbye, everybody. Thanks, everyone. Didn't know if we had to. Are these questions from anyone? Maybe they're not at their computers. Yeah, people who nipped for a wee. Okay. Oh, look. I don't know how to end. I can't end the recording, so we better leave. Of course, yeah. Well, just to say that the 15th of July, I think I can do that. I don't have a reason not to be able to do that. So yeah, I should be there. Okay, brilliant. Ace, thank you. Cool. All right, I'll speak to you soon. Bye. Bye.